Well, hello, and thank you for joining us. My name is
Hi
Bill
there.
Falone. My name is Bill Falone, and we have Karin Botti online with us. And Karin's coming to us from Pittsburgh, and she's going to have a terrific presentation about lymphedema. Let me introduce Karin for us. Karin is a certified occupational therapy assistant, licensed. She's certified lymphedema therapist and has a credential from Lymphology Associates of North America. In addition, she has Physiological Oncology Rehab Institute certification and graduated with honors in biopsychology from with a Bachelor's of Science from Penn State University. Karin has worked as a LANA board lymphedema therapist for more than 20 years with experience in outpatient, inpatient, and home care divisions with both adults and pediatrics. Karin developed the only inpatient lymphedema program in the U.S., which ran successfully for 12 years prior to the facility closing. Karin is presently the lymphedema program coordinator for AHN Healthcare at home and manages a team of 9 certified therapists and 2 LANA board certified therapists. She works closely with nurses and wound care specialists on non-healing and complex wound patients. This coordinated care results in excellent outcomes and improved quality of life for AHN's current home care patients. Karin's presentation today is lymphedema management related to wound care and why it matters. Please welcome Karin Botti.
Thank you, Bill. I'm happy to be here. As Bill stated, the title is Lymphedema Management Related to Wound Care and Why It Matters. But the subtitle is Full Utilization of Our Existing Standards of Care, because I really want to point out that we have the tools in our toolbox to properly manage these patients if we understand the complexity of edema and how it affects our wounds and their healing process. The objectives I would like for you guys to be able to meet today are that you will be able to verbalize what makes lymphedema a disease process. You will be able to differentiate edema from lymphedema in its early stage. You will understand the disease process and subsequent sequela. You will be able to identify medical disqualifications for compression. You will understand appropriate purpose for a variety of compression bandages, and you will be able to apply this newly learned information in a real-life clinical setting after review of this program and its case studies. As a disclaimer, the information throughout this presentation reflects results based on the individual clinical practice from inpatient, outpatient, and home care settings that I have experienced. All of the express treatment parameters, including the lab values, were established with close physician collaboration within our facilities by the physicians directly involved in treating the lymphedema patient population. Pre-admission medical testing and lab value parameters were identified as markers for safe treatment by our facility's individual medical specialists, and that the information reflected throughout this presentation does not represent official research, although unofficial in-house data was always collected to observe patterns, both medically and behaviorally, and has been considered when establishing treatment parameters. So what is lymphedema? There are lots of different definitions which I've provided here for you, but the top one is the one I want to focus on. It says that lymphedema is an abnormal accumulation of high protein edema in the interstitial spaces that causes chronic inflammation, skin integrity issues, infections, and reactive fibrosis of the affected areas. It causes peri-wound congestion, and it can be benign or malignant. I like that definition because it really describes what you're physically going to be able to see in a patient's limb. The other definitions are certainly appropriate and valuable to know, but that's the one that we kind of hold tight to explain what lymphedema actually is. On the bottom of the slide, you will see in the green print where it says lymphedema is a chronic condition with no definitive curative treatment that is progressive. So early detection and institution of decompressive measures are essential in avoiding its potentially disabling sequela. And I hope that that statement will make more sense as we go through this presentation. So what makes lymphedema a disease process? Well, there are many things. One of the biggest things is that it's a high protein edema, and those protein cells in the lymphatic fluid or the lymphedema causes collagen fibers to be produced. Fibroblasts proliferate. That makes it a connective tissue disease process. It carries its own ICD-10 code, currently I-89.1, but that is likely to change. Fatty tissue increases. Adipose cells also proliferate. It is frequently associated with infections, cellulitis, fungal infections, bacteremia. It has significant skin integrity changes. You will see fibrotic changes in the leg. It'll be hard, difficult to pit, sclerosis, induration, and certainly wounds. It will be accompanied by hyperkeratosis, which is that dark, thickened skin that almost looks like dirt on a patient's leg, and papillomatosis, which are those tiny wart-like projectiles that develop on a patient's limb. There are certainly other skin integrity changes that we'll review as we go through the program, but those are the two most common. The key takeaway here is that it is a disease process and that it is incurable, but it can be effectively managed. I want to talk a little bit about how edema versus lymphedema, and this will help us with our objective of learning how to identify when you have a lymphatic edema and what to do about it. Edema is simply a symptom of another medical problem. There is no ICD-10 code for edema. Thin fluid accumulates in the extracellular space. There are no fibrotic tissue changes. There's little to no risk of infection, and after treatment, a complete resolution is expected. So if you have edema secondary to a trauma and you go through your healing process, as you heal, that edema should resolve. Lymphedema is a disease process. It has its own ICD-10 code. The fluid accumulation is high protein and it affects the interstitial space. Fibrosis develops. There's an increased risk of infection. It is chronic without resolution, and it is paired with significant skin integrity issues. So hopefully that will help a little bit. There are specific characteristics that you can see, and they will help you in differentiating between the two. Often this information can be obtained through a thorough chart review and certainly a patient interview. Edema can have a rapid onset. It can be painful. If painful in the calf areas, you would always want to rule out a DVT, so a phone call to the physician to see if they would be willing to order a Doppler would be relevant. Edema responds to elevation, and it's pitting. There's no increase in volume of the proximal edema while in treatment. So if they have lower leg edema that you're treating, you're unlikely to get swelling in the thigh. Edema often presents as bilateral and symmetrical, and it's often accompanied with hyperpigmentation or other skin pigmentation changes. It really depends on the underlying cause. Characteristics of lymphedema is that the onset is generally slower. It's usually edema that's been around for greater than 3 months. It's usually not painful. If they elevate, they either have no reduction or less than a 10% reduction. It is non-pitting or very difficult to pit. And when it's difficult to pit or non-pitting, we can do a test called a stemmer sign assessment, where you pinch the top of the second digit of the foot. If it does not tent up and it kind of bulks up, that's called being stemmer sign positive. You can see an increase in volume of the proximal segment of a limb or the contralateral limb. So if you have congestion in your lower legs and it's being caused by something in the groin or axillary region, and you start applying compression, you may see an increase in swelling in the thigh or in the opposite leg. And it's accompanied by skin integrity changes. There are specific types of lymphedema. There's primary and secondary. Primary has 3 categories: congenital, which is present at birth or within the first 2 years of birth; lymphedema praecox, where the onset is typically around puberty or the beginning of the 3rd decade. It often is associated with hormonal changes in women. Lymphedema tarda is any diagnosis of lymphedema where there is no known cause and you're after 35 years of age. There are medical tests to identify and diagnose lymphedema that is primary, but without any known cause, it's considered a primary lymphedema. Secondary lymphedemas are our most common type of lymphedema. Worldwide, the most common type of lymphedema is filariasis. But in developed countries, cancer, CVI, treatments for cancer, surgeries, and disruption of the lymph node regions is the primary cause. It can also be caused by a malignancy, obesity, and there are some malignant lymphedemas such as Kaposi's sarcoma or Stort-Trevor's angiosarcoma, which is a vascular malignant tumor. So for secondary lymphedema, we know the cause of the swelling and the disruption to the lymphatic system, and for primary lymphedema, we do not. There are 4 stages in lymphedema. Oftentimes, I don't see a patient until late stage 2 or early stage 3, and sometimes stage 4. We would like to increase the awareness of lymphedema with all of you and other healthcare providers so that we can identify this condition earlier and provide more effective treatment. Stage 0 is also called latent or subclinical. Their limb may look normal clinically, however, they have abnormal lymph transport or slowed lymph transport. Your patient will likely have subjective complaints like, my rings are tight, my shirt doesn't fit well, my shoe on my left foot is snug, my arm gets more tired with activity than my other arm. So we want to listen to our patient when we ask them how they're feeling today and if they're having any changes. Stage 1 is considered early or mild. Elevation can still help, but remember, when the lymphatic system is involved, the reduction in swelling will most likely be less than 10%. This edema still may pit. Stage 2 is moderate to severe. It has a great range. Early stage 2 may still pit, but does not resolve at all with elevation. Late stage can include wounds and non-pitting with significant skin integrity changes and possible infection. Stage 3 is severe. There's fibroadipose deposition, significant skin changes, wounds, and most likely they've had a few infections. Stage 4 is elephantiasis, not frequently seen here, but not absent from our areas either. When you're evaluating your patient, the first part is your physical assessment and your history and physical review. This is very important because you can gain a lot of information. If your patient reports that they were not swollen at all last week, then you know that it had a sudden onset, and you're automatically going to think more venous than lymphatic, and you're going to continue your review down that pathway unless you find information that indicates otherwise. Your H&P review will help you discover if the patient has had any swelling in the past. Their disposition, are they staying at home? Are they in a facility? Are they living with family? Do they have caregivers that can assist? Do they not have caregivers that can assist? You're going to review their medications, and I would encourage all of you to learn a little more about pharmacology if you have the option. There are a lot of medications that lend themselves to develop swelling. Lisinopril is a common medication for high blood pressure that causes lower extremity swelling. You want to learn how to read lab values and which ones are relevant to you, and we're going to cover that today. You want to do a complete wound assessment, and you want to document everything. The second part of our evaluation is to develop our treatment plan. We use complete decongestive therapy protocols, which components are safe and appropriate is one of the things we want to determine. We want to begin developing that patient's home program and start engaging the patient in a portion of their program. Maybe it's the skincare, maybe it's having their bandages ready, maybe it's being ready when we arrive. So there's lots of opportunity to encourage your patient to participate at this stage. As you're going through your treatments, you're going to always be reassessing, but official reassessments are done by us once weekly, where we reevaluate the wound every 7 days, if it's there, or the limb volume and the skin integrity. At this point, you need to think about, are my wounds closing? Is the edema reducing? Is the skin integrity improving? Are they tolerating treatment? How compliant are they being? We want to look at those factors because if any one of those factors are not in line, we want to see why and do everything we can to make changes. If a wound is not closing and your treatment hasn't been effective for 2 weeks, we need to look at what changes do we need to make so that we can appropriately help this patient heal. All of this brings us to our home program. We want to design a home program that's effective for the patient. It may include a pneumatic device. It may include a progression into day or nighttime compression garments. Oftentimes the edema reduces and we might have a wound remain that's not significant any longer, but it's still there. At that point in time, we can encourage the patient to participate in their own dressing changes by teaching them how to remove their garments, complete their skincare routine, and do their wound care. At that point, a discharge would be appropriate. I call this section digging up dirt. We want to really talk about relevant labs and medical tests and how they pertain to our clinical treatment. Recommended medical testing includes a chest x-ray. If your patient has congestive heart failure or any pulmonary condition that we might be concerned about, we want to ensure that their lung fields are clear prior to treatment. Labs that I look at frequently are a CMP, a prealbumin, where I'm looking for the BUN and creatinine. I want to make sure their renal function is okay. And if it's not, I want to talk to the renal docs and make sure that we are following whatever protocols they would recommend. The prealbumin is an indicator of malnutrition. There are other ones that are out there and they certainly can be used, but this gives us a good picture of where we're at. The HbA1c for a diabetic patient, we want to make sure they're well in line and managing their diabetes and eating properly. Pro-BNPs help us determine how our heart failure patients are doing. It's a measure of their cardiac status. And we look at their PT-INR if they're on Coumadin, because if it's high and the patient's blood is really thin, they can actually engorge if they sit too long in a dependent position into a compression bandage or a garment, which causes petechia and other skin integrity changes. If there's a reason to have had Dopplers, we want to know if they've ruled out a DVT. But more importantly, we would like to establish an ABI so that we can determine what level of compression is appropriate. An echocardiogram lets us know that the ejection fraction is at a minimum of 30% if you're in an inpatient setting. In our home care setting, we don't go less than 35% because we don't have eyes on the patient 24/7. If the patient has lower extremity swelling and there's no clinical reason why, and maybe they're a female who's had reproductive issues in the past, we might ask the doctor for a CT scan. We've had a case where we had to rule out that there was any tumor blocking the lymphatics. Unfortunately, we did find a large mass in that particular patient's abdominal pelvic region. It was surgically removed and thankfully found to be benign, and the edema reduced quite quickly. We actually want a height and weight on the patient so that we can help develop an appropriate level of care and help manage any obesity-related issues. A key takeaway here is that although all these tests are important, I would like to be sure that you all understand that a patient can still develop blood clots even if they're on anticoagulant therapies. And if they're reporting pain, you still want to report it to the doctor and encourage that they rule out any kind of clots. Nutrition is a very important factor in healthcare, period, but for lymphedema, it's very important. If you're well nutritioned, you are more likely to absorb decongested lymphatic fluid. You will have an improved immune system response and you're less likely to accept infection. You have an increased metabolic response, increased cell matrix regeneration, increased energy production for activity, and your overall healing time should be decreased. This lends itself to lower healthcare cost and reduced risk of infection, improved healing. A malnutrition patient has quite the opposite. They have poor absorption of lymph fluid, they have a compromised immune system, decreased metabolic response, and cell matrix regeneration. They will have increased healing time, frequent recurrences, and they are much more susceptible to infection. That all lends to higher healthcare costs, antibiotics, recurrent admissions, tests, possible hospitalizations. We want to do everything we can to encourage appropriate nutrition in our patients. When we're treating a wound with the lymphedema patient, we have some common primary dressings that we use. The most common wounds that are related to lymphedema are our venous stasis ulcers and pressure ulcers. Our most frequently used primary dressings would include antimicrobials, bacteriostatic foams, calcium alginates, collagen, hydrogels, and oil emulsions. Note that they are all thin, they lay flat, they will not create additional pressures from the borders. The goal of using one of these primary dressings is to keep the wound bed moist, prevent infection, debride if needed, and to facilitate epithelialization. Common secondary dressings for patients that have drainage are ABD pads, foam, gauze, hydrocolloid dressings, non-adherent dressings, and super absorbent pads. Regardless of the product used, the edges must lay flat or they must be able to be beveled to prevent pressure areas under a compression wrap. There's lots of types of compression bandages. The Uniboot is popular in the wound care setting. It's single layer. It has a light compression. It has a negative pressure gradient. It's used for arterial and venous patients with mild or no edema and new wounds. It does allow swelling if the patient stays in a dependent position too long. It can cause strangulation if it's inappropriately donned. It is affected by dependent positioning. However, if your patient is using an Uniboot and they are successful, then the appropriate compression garment would be a ready-to-wear wound compression garment with the liner if possible. Another compression bandage system that we like a lot is the 2-layer Coflex. It is utilized with padding. It's multi-layer. It can have a positive pressure gradient through modification. It provides up to 18 to 20 millimeters of mercury in compression. We use it for arterial, venous, early stage 1 and 2 lymphedema patients. It's appropriate for CHF patients and for patients with fragile skin integrity. It is not appropriate for thighs, and it still can be affected by dependent positioning. A comparable garment for that would be a light custom 15 to 20 millimeters of mercury or a 20 to 30. The Comprelon multi-layer bandage is a true lymphedema wrap. This is quite extensive and multi-layered. You utilize it with padding. Sometimes it's gray foam, 1/4 inch or 1/2 inch. Sometimes it's rolled foam. It's a positive pressure gradient from the toes to wherever the bandage ends. It could be to the knee or to the thigh. It can be combined with other materials such as isoband or even tubagrip. It has a much higher pressure of 22 millimeters of mercury or higher, and it's used specifically for lymphedema. It is not usually affected by dependent positioning, but if there's incorrect pressure within that bandage, it can be. If a patient has a true lymphedema wrap, a ready-to-wear or over-the-counter garment would never be an appropriate referral. For lymphedema, a comparable garment is a compression class 2 or 3 custom flat knit garment only. Some types of compression garments that we frequently use are the custom daytime garments. This is a compression class 2 Alvarex knee-high garment that is measured specifically for this patient. It is a flat knit fabric and will not allow the patient to swell. A garment popular with our wound care patients is the Circade Juxtalite HD. It has a nice range with its Velcro straps, has a sock that underlies the wrap that has light compression in the toes from the MTP crease to the ankle. The rest of the sock is a soft liner that's stretchy and protects the skin. Sometimes patients who can't tolerate bandaging or need to remove bandages for wound care with nursing or to shower for skin integrity, they can use a Circade reduction garment. This is a multi-layered system that looks really complex, but it takes the place of the compression wraps. Your lymphedema therapists are actually edema management specialists, and I would encourage you to use them as often as you can. They can assist the physician and you with differential diagnosing. They recognize that not all edema is lymphedema. They understand that edema etiologies include vascular disease, dependent positioning, orthopedic-related issues, post-trauma related injuries, and can be present in chronic pain in RSD patients. Chronic edema is a significant contributing factor regarding development of adhesions, scar tissue, decreased function, and pain. Chronic edema is closely associated with recurrent infections, frequent hospitalizations, and can be associated with high number of falls in the geriatric population. Not all edema is bad. The first 2 weeks after a trauma or surgery, swelling is normal. It brings macrophages and T cells to kill unwanted bacteria and germs into the region that needs to be healed. The problem is if it doesn't resolve, then we need to get involved and help it along. Gunter Close from Close Training in 2008 stated that prompt reduction of edema dramatically enhances functional therapeutic outcomes and rehabilitation, and we have found that to be very true. There are many types of lymphedema, and your patients certainly will have more than one diagnosis normally when you see them. Lymphedema is a genetic condition where they are genetically prone to developing excess adipose tissue from the iliac crest down to the knees or the ankle areas. Lymphedema is very tender. These patients bruise easily. They have poor tolerance for bandaging. Nighttime garments and daytime garments are difficult for them. Lymphedema is very congestive. So the patient develops a lymphatic swelling and a combined form or mixed edema of lipolymphatic edema. Obesity is very similar to lymphedema, except that it's not genetic. There is a significant amount of adipose tissue. The severity determines the outcomes. There are clear parameters for treatment. Patients have to actively participate in a weight management program. You can have fatty tissue blockages. Nighttime garments and possible knee-high daytime garments are the treatment of choice for these patients. CVI with or without ulcers. May have cardiac considerations. Dopplers in a standing position if possible. Vascular referral to roll-out reflux. Often these patients have chronic wounds. We need to treat this phlebolymphostatic edema. If it's primarily venous, knee-high garments. If primarily lymphatic, they may need more. Cardiopulmonary patients, the phlebolymphostatic edema, congestive heart failure, right-sided pulmonary hypertension, sleep apnea patients. Anasarca is strictly a medical problem, and we do not treat that, but unfortunately, we do receive a lot of referrals with that diagnosis. The ejection fraction must be greater than 30 to 35% for these patients. Orthopedic, traumatic edema. Again, not all edema is bad. If the edema is there for the first 2 weeks or so and it's not resolving, we may need to get involved. But if it's resolving, then we just watch it closely. It could just be a venous overload, or it can be lymphatic. It's individual to each patient and mostly related to length of time that the edema-related issues have been present. Renal patients have metabolic-related issues. We work very closely with nephrology, modify garments. Sometimes we use compression socks. And more oftentimes, we're very successful with patients on dialysis if we treat them the day before they have their dialysis treatments. Cancer patients, through either their cancer tumor or their treatments, have an actual lymphatic disruption. It's true lymphedema. And we want to watch that closely because it can also be a malignant edema. Wound care, lymphedema, and decongestion. Chronic wound patients understand that chronic wounds don't heal, they close, and they reopen if the peri-wound edema is not addressed. It can also be a breeding ground for bacteria and a source of recurrent infection. It can be painful. It's associated with high healthcare costs. It takes an emotional and mental toll on the patient and their family. We know that a wound is never referred to as having healed until it has been closed for more than a few months. The primary reason for frequent exacerbations and return to the clinic, and it's actually more frequent than non-compliance issues, is that the peri-wound edema has not been managed. Scar tissue forms to close the wounds. The strength is only at best 60 to 7%, and that decreases with each recurrence. Daily decongestant is imperative to facilitate healthy peri-wound region and wound healing. The picture you see on your left is a surgical wound with cellulitis and a fungal infection, which was identified after the patient's cast was removed. The picture on the right is a severe venous insufficiency patient who continues to get a recurrent dorsal pressure ulcer and anterior ankle rings due to negative pressure bandage. They were using Tubigrip. They also have severe hemosiderin staining. An example of your chronic venous insufficiency patient with an undiagnosed lymphedema is this gentleman. He had venous stasis ulcers, a Pseudomonas infection, MRSA, he has severe fibrosis, a fungal infection, cellulitis, and moderate cirrhosis. And they were frustrated with the fact that he wasn't healing. This is severe cellulitis and dermatitis that is often associated with lymphedema. This is a lipedema patient who has massive lipolymphatic elephantiasis. This patient would need severe liposurgery, some reconstructive surgery. Our goal with these patients is to try to do as much as we can to manage and prevent recurrent infections. This is elephantiasis of the foot and ankle. Elephantiasis is where the damage is so severe that your limb is almost unrecognizable and often looks like petrified tree bark. Lipolymphedema is often characterized by some pretty significant skin integrity issues, papillomatosis, which are those wart-like projections, or lymph cysts, and cellulitis. Filariasis. This is the elephantiasis patient that was in the previous slide. Filariasis is caused by a parasite, and it's often not seen here in the United States, but with many of our soldiers in other places right now, we are seeing some cases. There is severe soft tissue malformation, severe skin decompensation, multiple infections, and underlying wounds that we can't see until the patient initiates treatment, and then they have the opportunity to present and receive appropriate treatment. The key points to this section is that a complete physical exam is a must. Listen and watch your patient. Learn about your medications. Communicate with your referring physicians. Establish an effective home program and begin to train the patient and family on evaluation. Understand and discuss with your patients the need to continue MLD, either manually or with a pneumatic device, to facilitate ongoing lymph fluid absorption. Don't be afraid to make changes. If you're doing something for 2 weeks and it's not working, reevaluate. Be confident and document everything you can think of or see. The first presentation today for the case study is a 74-year-old man with severe venous stasis and recurrent cellulitis and wounds. He had recurrent admissions to the inpatient center, but kept coming back. His initial wound measurement was 3.5 by 4.0 by 0.1. He had decreased sensation, decreased nutritional status. He had a 19.5 weight loss recently for no known reason. He had chronic leg ulcers. His current weight was 252.1. He had fungal infections, cellulitis. He was VRE positive. He had weak pedal pulses, slow mentation, and a Braden score of 19. Doesn't look that involved, but it continued to reopen and reopen and reopen and get infected, and it required frequent inpatient admissions to manage that. Considerations for treatment was his SED rate was 66, his HbA1c was 8.2, and his infections through positive cultures required IV antibiotics and topical agents for bacteremia, cellulitis, and fungal infections. We did ultrasonic debridement 3 times a week for the first week, bacitracin, adaptic, and ABD pads, and used a double layer short stretch with a 1/4 inch foam on this gentleman. Our labs were reviewed with the physician. We had topical agents to improve the skin integrity. We used pressure relieving surfaces. Compression gradient recommended for physician approval was the double layer short stretch for wound support. We used manual lymph drainage and pneumatic devices daily on his trunk and thigh. We provided extensive patient education and established an individualized home program, which was challenging due to his inability to read and slow mentation, and he did not have family support. After 2 weeks of inpatient treatment, his wound closed. His discharge plan was that he was educated on skincare products and skin integrity inspections. He was also assisted in the procurement of his compression class 2 knee-high garments to align with the compression in his bandages. Lower body ADLs for bathing and donning and doffing his garments had improved from max assist to overall independent. He had an opportunity to practice his home program repeatedly to help increase compliance. And we were advocates for appeals with this patient's insurance company so that he could get coverage for the garments necessary. He also received a social service referral for in the community to provide him assistance. The second case study is a 62-year-old male patient with severe venous stasis and venous stasis ulcers. He was referred initially from another outpatient clinic for evaluation for the inpatient program which his insurance denied. He had obesity. He had had his left kidney removed secondary to cancer. He was using bilateral lower extremity pneumatic devices, first for 1, then 2 hours daily. He had a history of multiple infections. He had severe skin integrity issues, and he was unstable insulin-dependent diabetic. On eval, it was found that he had red, warm legs. He had cellulitis, fungal infections, pseudomonas. He had severe fibrotic tissue, papillomatosis, hyperkeratosis, and limb cysts bilaterally. We consulted with his physician. His chest x-ray, echocardiogram, renal panel, CMP and prealbumin, and HbA1c were completed. His most current H&P indicated a recent CHF episode, pulmonary hypertension, and sleep apnea. Patient had not been compliant with use of his CPAP, and he needed a 3-liter bleed. Lengthy discussion with patient and wife about compliance and the need for cooperation for any chance of success was provided, and he agreed to try this one last time. He was very discouraged. He had been in and out of multiple wound clinics and multiple lymphedema clinics without success. We put him on a 5-day hold for the patient to get back on track with meds, use of his CPAP, and to stabilize medically. Cultures were taken from the wound areas, and the physician began the appropriate antibiotic. After initiating treatment, some of that superficial fibrosis softened and allowed the underlying wounds to present. They were painful, burning, they had drainage, they had odor. The dead skin had sloughed off, leaving raw, sore, open areas, but at least we had an opportunity to see what was under those areas that was causing these recurrent infections. The treatment plan for this gentleman was manual lymph drainage massage, initiated bandaging over physician-ordered wound dressings of silver alginate with safe gel, ABD padding secured with Curlex. We used a double-layer short stretch to the knees over 1/2-inch gray foam, padding, and toe wrap. We began training the wife to apply the bandaging and to manage the materials. Patient education for a home exercise program, and a referral to Joslin Diabetic Center with instructions for patient to have an appointment by the next visit were provided. His initial limb volume was 16,364 milliliters on the right and 16,435 milliliters on the left. Complications occurred as he had pain increase and his volume decreased secondary to his neuropathy. His physician initiated Lyrica. It's slightly easier on the kidneys than Neurontin, and Neurontin can cause swelling. Proximal limb volume increased despite the manual lymph drainage massage. So as we were treating his lower legs, his upper legs were swelling. We started to bandage his thighs and increased his compression. He had ongoing infections. We referred the patient to an infectious disease specialist. Despite compliance with the program, his progress would wax and wane. He would come in one day and be doing better, and the next day not so well. We made additional modifications. The infectious disease specialist changed his antibiotics and added another low-dose long-term antibiotic. We initiated the pneumatic device for the trunk and thigh portion to be used 2 times daily at home, and we taught the wife how to rebandage the thigh portion of his legs after each treatment. We increased bandaging to multi-layer short stretch and gave him full manual lymph drainage massages on treatment days in the clinic. The physician added a low-dose Lasix and watched his renal labs. Slow but steady, he made progress. His limb volume decreased bilaterally, his fibrotic tissue softened, his skin integrity improved but was still fragile. Pain decreased, wounds were closing, he had increased independence with his home program and increased compliance. He was motivated to be compliant because he was seeing progress. His HbA1c was improving with the nutritional counseling and help that he got from the Joslin Diabetic Center, and he was presenting with increased mobility. His right lower extremity volume had decreased 2,083 milliliters, and his left lower extremity volume had decreased 1,727 milliliters. After 10 weeks, he had remaining hemosiderin staining and a few open areas. No open areas in the front of his legs, and only some small open areas in the left posterior calf. These patients can do very well if the compression is managed and treated along with the wound. Treating one or the other alone is not the most effective approach. I hope that you learned something today. or reinforced information that you already knew. And thank you so much for your time.
Karin, thank you so much for that fascinating review. That's incredible. And boy, I just realized how much I don't know. That's amazing stuff. Thank you. I do have a couple of questions.
Yes.
You mentioned that there was a one type of lymphedema where the patient's legs were sensitive and compression was difficult without causing discomfort. What do you do in a case like that?
So on the slide where we demonstrated the different types of garments, the circade reduction garment is one of the things that we can use for those patients. They are more receptive to that because they're in control of how snug it is applied. The other option is to treat the patient with a lower compression wrap just to the knee and encourage the use of a pneumatic device to help massage the upper leg. And sometimes even the over-the-counter compression biker pants that you can get at a sporting goods store are enough to help these patients tolerate a little more activity.
Really? That's interesting. Yeah. Oh, great. I'm wondering, is there a particular diet that would help resolve any kind of lymphedema, or I should say manage lymphedema?
So we encourage patients that are medically safe to do this, and that would mean probably not be your renal patients, but we encourage patients to have a high hydration, low sodium, high protein diet. We teach them about eating 5 to 6 small meals a day, managing their portion sizes, and making sure there's protein with every meal. If it's a renal patient, we certainly talk to nephrology and we find out what their recommendation is.
And the folks that are morbidly obese, are they more or less, or any different in terms of the likeliness of becoming lymphedema? Or
Absolutely. Absolutely. Adipose tissue is really sneaky, and it's so frustrating to deal with. And I understand the frustration for this patient population. Adipose tissue proliferates. So you often hear patients say, I lost 10 pounds, but I gained 20 back. That's true. Adipose cells multiply by themselves. So if I lose 10 pounds and I lose a quick example would be 10 fat cells, but I gain that weight back, instead of gaining my 10 fat cells back, they proliferate, they multiply by themselves. So now I have 100 additional adipose cells.
Wow.
So it becomes horrifically congestive and it's very difficult to manage. And these patients get so frustrated. So we like to refer them we have multiple bariatric programs in our area. We're fortunate for that. And we send them there for information, education, nutritional counseling, psychological counseling, metabolic studies, because oftentimes you find that this isn't an overeating issue. And I will say that the majority of the time, our obese patients are malnutritioned because a lot of them are trying to starve themselves to not gain weight, and they're gaining weight anyway. You have to eat to lose weight. You just have to do it properly.
Wow. Oh, no kidding. A lot of information there. Again, thank you so much for sharing it.
Thank you for having me.
Please. It's been very, very interesting. To our attendees who are watching this presentation, here's a reminder. You must complete the presentation evaluation and submit it prior to December 31st of this year to earn a CE for this presentation. And we are going to stop recording now, and thank you again, Karin.
Thank you so much for having me. I think I'm okay.